Did you know that as many as 1 in 5 older adults suffers from some form of mental illness? Mental health issues are increasingly a concern of housing and community service providers. At Jewish Family and Children's Service, or JF&CS, we bring more than 20 years of experience to working with older adults in the field of mental health. We recognize the need to foster caring housing communities that are equipped and empowered to address mental health issues and support a population of diverse and deserving older adults. Hello and welcome. I'm Kathy Burns, Director of the Services for Older Adults Division at JF&CS.
And I'm Robin Krausick, a geriatric social worker at JF&CS.
We'll be leading you through this 1-hour webinar that's a companion to our Tips and Techniques guide for supporting residents with mental illness. While this is a guide written for staff in housing for older adults, and you will frequently hear us use the term resident, the mental health information included in this guide is relevant to any provider working with older adults in any community setting. Before you begin, you might want to pause now, as we recommend you download the guide before beginning this webinar using the link above. This will be helpful because throughout the webinar, we're going to make reference to specific pages within the guide. I'd like to add a note of caution. This is not meant to be an all-inclusive study of mental illness or a teaching tool for you to diagnose. That can be risky business, and it's always better left to the expert. Rather, this is a resource to refer to when you face challenging behaviors or you seek to gain a better understanding of older adults living with mental illness in your setting. This guide will make you aware of some of the signs and symptoms that indicate an individual may be struggling and provide you with some practical advice and language for effective intervention. We hope that access to this information will further your efforts in accomplishing the shared goal of supporting our older adult community members in living safely in their homes. This 1-hour webinar will provide you with an overview of our Tips and Techniques guide, and will provide a framework for putting together a comprehensive plan to address the mental health issues presented that are commonly found in senior housing sites or in community settings for older adults, based on case examples and commonly found scenarios. We hope you will embrace this team approach as an effective way of working with residents who may be struggling. We understand that this type of planning does not always take a straight and narrow path. Like Lombard Street in San Francisco, there are always lots of twists and turns, traffic jams, roadblocks, detours, and maybe even some road rage along the way. For this reason, we don't use the word solutions, as these situations are not easily fixed, but they can be managed with a lot of thoughtfulness and collaboration. The Tips and Techniques guide will provide you with answers to common questions you may have. You may find yourself in situations involving mental health issues that you may not feel prepared to handle. The guide will arm you with some essential information, including basic assessment skills, de-escalation techniques, suggested language you can use when speaking with a resident who may be angry or upset, and some ideas in how to further collaborate with family members, other staff, or community resources to put a plan into place to assist a resident who may be struggling. And finally, the guide will also provide some case studies that will bring to life examples of the mental health disorders that might be commonly found in older adults, and then some context for managing these difficult situations and providing assistance to residents. Don't forget to make your way to the back of the guide for perhaps the most important page, which is the Mental Health Partners Resource List. You should fill this out, including all of your local resources, and then make it available for staff so that when a problem comes up, you'll be prepared, and you're not going to have to fumble around in the midst of a crisis trying to locate names and phone numbers. So please post this resource in a prominent place so everyone has access, and then update it regularly.
When mental health challenges and aging issues intersect within a community setting, this poses some very unique challenges to you in your role as a staff member. For many years, I worked as a guardian case manager here at JF&CS. I often stepped in the midst of this intersection, and I have a true appreciation for those staff who are the boots on the ground, professionals dealing with these challenging cases every single day. When I'm on the road training housing and other staff that work with older adults, I often hear very similar stories. The names may be different, but often there are situations commonly found across the board. The case studies we will highlight today are fictional, but they represent a composite of cases that we've heard about throughout the years, and they are all based on true stories. We know that one person's behavior can impact many other residents and staff in housing or in any group setting. Just think about what happens when someone with a long history of paranoia begins to scare other residents with talk of strange men entering their apartment or toxic gas being pumped in through the air vents. Or when someone's behavior is affecting another resident's right to the peaceful enjoyment of their homes. What behaviors should prompt staff to intervene? How can staff receive supports from the community to work with a situation like this to support both the individual struggling and also the community around them? The format for today's webinar will be to introduce two case studies to you. For each one, we will review the key components from the guide. We will review assessment criteria. We'll highlight some of the dilemmas faced by staff in working with these residents and guide you through the planning process. The process includes pulling together an Action in Community or ACT team. We believe the team is the most effective way to manage these difficult situations. Often there are many local community and government agencies involved, and being able to communicate and collaborate with these resources will certainly increase your chances of more effectively managing these situations. And finally, we'll provide practical tips and techniques for things to say and do. Before we introduce Margie and use her case example to begin to explore some of these questions, we would like to make a note of caution. If a resident refuses to allow you to be of assistance and you feel they might be at risk to themselves or others, please contact your state or local area's protective service unit. And if any situations you face ever pose a risk of physical harm to you or other community members, never hesitate to call the police or 911. Now, let me introduce you to Margie.
I'm managing just fine on my own. My apartment just needs a little tidying up, and there's no way I'm going to let any stranger come in here and rifle through my things. I know what those people do. These so-called aides come and steal from people like me. Do you think I'm made of money? I'm on a fixed income, so I don't have any extra money to pay for a maid. Forget the doctor. I feel just fine. And last time I went, he rushed me in and out so fast, I barely had time to have my blood pressure taken. And all of that took the whole day, because it took me 3 hours to get there and back using the ride. Doctors today are only out to make money. Their offices are like a factory. Of course, I'm not a bucket of sunshine. I'm old and alone. Oh, I never get to see my grandchildren. What do you expect? I keep to myself and don't cause trouble, so let me be. Aw, what does it matter anyway? I'm no use to anyone anymore.
Margie is an 83-year-old woman who's lived in senior housing for 13 years. Her husband died 2 years ago, and their only son died many years ago. She's estranged from her daughter-in-law and grandchildren who live on the West Coast. Margie and her husband kept pretty much to themselves. Margie has minimal involvement with her neighbors. Staff really only see her at yearly compliance meetings or if she has a maintenance need in her apartment. But for the last couple of months, Margie's been calling frequently with complaints of leaks and odors in her apartment, but maintenance has been unable to substantiate any of these issues. They noted that Margie's apartment was quite dirty and that this was new for her. There was food that seemed spoiled on the kitchen counter and in the sink. When they asked Margie about this, she simply insisted that her refrigerator worked just fine and there was no need to worry. The resident service coordinator named Joan arranged to meet with Margie in her apartment. During the meeting, Joan noted that Margie appeared to have lost weight, was badly in need of a haircut, and had a strong body odor. The apartment needed a major cleaning, but she refused a referral for housekeeping assistance to the local ASAP, the acronym for Aging Service Access Points that provide services for older adults. Are you concerned about Margie? We are. In a few minutes, we'll talk more about the specific concerns you may have noted about Margie. The end is in the beginning. This statement references a few key ideas. The first is that it's important to be mindful of the expectations we set up when we first encounter an older adult in our setting. Any routines we establish at the beginning, such as assisting older adults with errands or bringing them food, will be hard to pull back from as time goes on. Think about establishing clear boundaries with residents from the start. This statement also references the importance of noting someone's baseline functioning when you first meet, so that as time goes on, you'll be able to recognize and document any significant changes you observe. Assessment is explained in more detail on pages 5 and 6 in the guide. But before we talk about Margie, we'd like to review the basic assessment skills that are critical when interacting with older adults so that we can apply them to her case study. Even though you're not formally trained to do assessments, your input and feedback is invaluable. You or other staff, including the RSC, property management, maintenance, or even receptionists, are often the frontline first point of contact. Whether formal or informal, an initial assessment gives baseline to monitor for changes, and it can be a helpful tool for staff and families to understand level of changes in residents in a concrete way. Are you noting any concerning behaviors that might be new for an individual? Make a note of any unexplained changes in someone's normal routine. Has Harry stopped taking his morning walks or attending activities? Use your intuition. Any changes that are out of the ordinary can be a warning sign that something's going on, even if they don't appear concerning. I'll give you an example of this. For the last 2 years, Mary used the elevator to get to her apartment on the second floor to avoid any chance of falling. But lately, she's begun to use the stairs instead. While this may seem like normal behavior, it is out of the ordinary for Mary and may indicate a lack of judgment or safety awareness. Make an effort to document dates and times of these concerning behaviors, as it will be much easier to speak with family or professionals about these concerns when you have clear examples. Appearance. Appropriate dress. Is a resident appropriately dressed for the season? Or are they wearing a parka when it's 90 degrees outside in August? Personal hygiene. Are their clothes clean, or are they wearing the same clothes every day? Do they have a strong body odor or smell like urine? Is their hair unusually dirty or messy? For a man, is he unshaven if this is not the norm? Is someone forgetting to use their cane or walker if it's needed? Speech. Is their speech slow, fast, loud, soft, or very pressured? Are they not making sense or unable to get to the point, off topic? Are they mumbling or having difficulty answering questions, swearing uncharacteristically, or making inappropriate comments as if they have no filter? Are they talking to themselves? Are any of these new behaviors? Physical presentations. Are they agitated, fidgety, or pacing? Are you noting unusual facial movements, including mouth movements, tremors, or that empty look? Is someone intruding on another person's personal space boundaries? Are they having difficulty making eye contact or staring inappropriately? Mood. Is the person showing signs of extreme sadness, fear, or elation? Are they crying often, or perhaps showing no emotion at times when it would be expected? Are they agitated, making outbursts, or engaging in any behavior that affects others' right to the peaceful enjoyment of their homes? Cognition. Is the person oriented to time, place, and person? Are they struggling to remember your name when they once knew it well? Or having difficulty remembering the correct day or time, forgetting meals, or losing keys multiple times in one day or week, or perhaps looking at their keys and not knowing what they're for? Are they missing scheduled appointments or deadlines for rent payments, or paying the rent multiple times in 1 month? Are you seeing any signs that their memory or judgment might be impaired, or new signs of paranoia, afraid that people are out to get them or breaking into their apartment and stealing their belongings? Is a person unable to perform their usual daily tasks? What should you do if you or staff or residents are noticing any of these types of changes in an older adult? Make a mental or written note of these observations, then speak with other staff about your concerns. If this persists for more than a few days, talk to the older adult, ask them directly about what might be going on. If you have permission, speak to their families. Perhaps set up an initial meeting between the executive director, social worker, and family members, or any key players in this person's life. For older adults, often the best place to start is with a thorough physical evaluation. This is because physical problems can often be disguised as dementia or mental illness. For example, the symptoms of a UTI or urinary tract infection or dehydration may include delirium, confusion, and irritability, which are often associated with dementia or depression. Often these symptoms can be easily treated medically, effectively reversing the symptoms. On page 16 of the guide, there's a chart that highlights these subtle differences in the presentation of dementia and depression. Because these can be easily confused, this is one of the reasons that we encourage only experts to diagnose these disorders. Now let's think about assessing what's going on for Margie. The following are some concerning changes you may have noted about Margie. Her appearance showed signs of weight loss. We noted that her hair had not been cut lately, and that her body odor indicates she may not be bathing properly. Her speech was flat with lack of expression. Her mood was depressed, and she expressed signs of hopelessness and lack of purpose. Her cognition had changed. She was showing signs of paranoia and possible delusions that included the unsubstantiated complaints of leaks and odors in her apartment and paranoia that the aides would steal from her. Other concerning behaviors included change in housekeeping routines. Remember, her apartment was unusually dirty for her. And a lack of judgment and awareness relating to food safety. Remember the spoiled food in the sink? So what's going on with Margie? The guide will provide an overview of the most common diagnoses among older adults. Please review these diagnoses so that you may simply be aware of what you might be seeing and not to make a diagnosis yourself. Always know to get help from trained professionals if you suspect someone has a mental health disorder that needs addressing. Here's a list of some of the common disorders that are found in the older adult population that could potentially be the cause of concerning behaviors. The list includes personality disorders, dementia, mood disorders. We will cover the most common, depression and anxiety. Substance use disorders, especially the overuse of alcohol and prescription medications. Psychosis. Each of these disorders is described in the guide, so be sure to read up on these. For Margie, based on the assessment criteria, a trained professional would first consider a medical evaluation to rule out a new medical problem or infection, and then consider differential diagnostic possibilities, including depression and/or early dementia with possible delusional thinking. Remember those strange leaks, smells, the accusations of people stealing? Does Margie need to be screened for suicide? She certainly expressed feelings of hopelessness and discouragement. For your effort to be most effective, we believe that you should first have buy-in from all of the agencies and local community organizations involved. Identify your roles. Who does what best? Is there a good cop, bad cop? We encourage looking at problems from different points of view so that solutions are reality-based and not just developed through one lens. What are your alternatives if you don't have these internal supports? Can you join with other housing sites? If not, can you utilize folks from community agencies you work with, such as the Council on Aging, Veteran Services, or your community mental health center? It's important to develop good working relationships with your community agencies so that they're readily available when you need them. When meeting with the Action in Community or ACT team that you bring together, start by clarifying the problematic behaviors you would like to address and be specific. Discuss what you or others have already tried, what's worked and what hasn't. Identify what sources of support there are. And be specific about what your steps will be with the resident and others you need involved. And always collaborate with all possible resources in your community that are available to help. It takes a village. This diagram highlights the key players, or the village, that got involved in assisting Marjorie. The team includes a variety of professionals, including the RSC, housing staff, including facilities, an outreach coordinator or social worker from the local ASAP, the public health nurse, a mental health clinician from the community mental health center, and potentially protective services if Margie continues to refuse services. When we begin to come up with a plan for intervening, it's important to identify the problematic behavior. Who is it a problem for, and what are the risks involved? Are there risks to the individual or risks to the community members? Think about the ABC approach, which stands for antecedent behavior consequences. Be a detective. Think about what is going on before the problematic behavior occurs, the who, what, and when that might be triggering problematic behaviors. Remember the important need for a team approach. It's always challenging to have a consistent approach across shifts when different staff members are getting involved. Here are some other things to consider. After your assessment, what are your concerns you're noting, and which of them takes priority? Next, outline the steps you'll take with both the older adult and with the others involved. Think about the possible obstacles and plan to address them. And once a plan is in place, monitor the progress of the resident and adjust the plan accordingly. Planning for Margie might include beginning with physical evaluation to rule out any conditions that might be a potential cause of her problems, and if nothing surfaces, then to move to a neuropsych evaluation to rule out the possibility of any cognitive impairment or mental illness. Then contact the local ASAP so they can put some services into place, such as heavy chore cleaning, home-delivered meals, or a home health aide that could come in a few times a week to assist with personal care. Remember, Margie was losing weight, not eating properly, and having trouble with grooming and personal hygiene. Does she have dementia, or could it be something reversible? The diagnostic possibilities may include depression and/or early signs of dementia with possible delusional thinking. Engage mental health services if it's appropriate. And be sure the RSC makes efforts to engage Margie in some type of community activity or connect her with a friendly visitor to encourage social engagement, which can be so important for mental health. And if Margie continues to refuse services, then as a last resort, it might be time to make a referral to protective services. What else might get in the way of helping Margie? The road to managing these situations can be anything but a straight and narrow path. Here are some of the common roadblocks, detours, or dilemmas that we face when trying to find solutions or manage complicated situations involving older adults. Consider the issue of safety versus autonomy. As we stated earlier, the shared goal for all who work with older adults is to empower them with the resources necessary to remain either living at home or in the least restrictive setting possible. We are charged with respecting each individual's right to self-determination, but sometimes it's not clear as to when the risk of self-harm outweighs this right. Whose decision is it to make? This requires a delicate balance of thoughtful planning. For example, if an older adult is wandering outside in the middle of the night, are they safe to remain living alone? Or can any supports be put in place to allow them to remain safe at night? If not, then maybe the setting may no longer be appropriate. Is the resident's behavior impacting the other members of the community? Ask yourself, are there risks to others? Could someone with early stage dementia start a fire if they forget about a pan on the stove? Someone wandering at night banging on others' doors? Are staff and neighbors being accused of stealing things? Is this individual's behavior getting in the way of others' peaceful enjoyment of their environment, which is every tenant's rights? Are there complicated family dynamics getting in the way? Sometimes unresolved family issues from the past certainly get in the way of family members' willingness and appropriateness to help plan for an older adult. Or family may refuse to recognize dementia symptoms and be in denial, insisting that their parent is okay. How much can or should we get involved, and how? What about when siblings have different takes on their parents' needs? This is not unique to dementia, but certainly most challenging. This is where having documented, accurate accounts of problematic behavior to relay to family members may help them take notice that this is serious and an immediate issue that needs attention. But what if family's not involved, or there is no family? If no family is involved and a person is no longer competent to make their own decisions by virtue of a neuropsych evaluation, it may be time for protective services to get involved and consider appointing the individual a court-appointed guardian to assist with decision-making. And the ultimate question, when is it time for supportive housing? Though this is never the solution we hope for, an individual who's suffering from dementia or mental illness that is struggling to remain safe and well cared for may thrive in a more supportive setting. Our experience has shown us that in some cases, moving an older adult really can benefit them in many ways. It's not always a bad thing. One more tip. When it's time to put supports in place for an individual, be mindful of the approach you take in order to avoid refusal of services. For example, never send a brand new provider, such as a nurse for assessment or home health aide, to the house of a person with dementia without proper consideration of how they might react to this stranger appearing at their door requesting to come in and examine or bathe them. Imagine, for someone who's already struggling with confusion, this will likely cause great distress, and it's very unlikely that the individual will welcome this helper into their home. Be sure that when introducing new caregivers to an older adult with dementia, to have someone they know and trust be present to ease the transition. It certainly may take more time and effort, but it will be time and effort well spent. In Margie's case, here are some of the dilemmas that presented. Margie had no known support network, as she often kept to herself, and she had no family. If you remember, her husband and son were both deceased, and she was estranged from her daughter-in-law. What was Margie's impact on the community? Was there a potential health hazard of having spoiled food in the building? Was this a health hazard or a situation that might attract pests? Do her complaints of leaks and odors cause other residents to panic? Has the time come for an alternate setting for Margie? Or does she need more support, an assisted living facility, or just more services put in place? Is she refusing services? Is she capable of making her own decisions? Should protective services get involved? Throughout the guide, there are many charts showing the suggested language to use for different disorders. To begin a productive conversation, always express concern for the older adult, as they likely are suffering. Offer encouragement and support in any way that you can, and provide resources so that they can access the help they need and know where to turn. And always check in and follow up in the following days or weeks to let the person know you care and that you're still there for them. It often takes time to build trust and for the older adult to engage in seeking assistance. Page 10 in the guide shows a chart with suggested language for speaking with someone who's depressed. This may give you some ideas about how to approach what is likely to be a difficult conversation with Margie, and will give you some examples of how you can approach someone like Margie in a helpful way. For example, it's helpful to express empathy and give an example of why you're concerned when beginning a conversation. You might say, "Margie, I've been concerned about you lately. You've lost a lot of weight, and I'm worried that you aren't eating well and don't seem to have the energy to keep up with your chores. I know you don't have a doctor you trust, but the local ASAP has a really great nurse that makes house calls. I would be happy to set up an appointment for you, and I could be here to introduce you when she comes. Many of our other residents use her and trust her. I think you might get along well with her, and I'd love to see you feeling better." It might also be helpful to follow up on her statement that expressed hopelessness to determine if further screening for suicide is necessary. You might say, "When you said that I'm no use to anyone anymore, does that mean you think about suicide?" It's very important to open the lines of communication with someone that shows any signs of suicidal ideation, and then get help if the person expresses an intent to die, a plan, and might have access to means. It's important for all housing staff to be properly trained in suicide prevention, as it does happen in every community. This webinar will not cover suicide prevention, but you'll note at the end there are some resources provided to assist you further. You'll note that there's evidence that Margie may have been experiencing delusions. So what do you do when someone reports something that sounds like a delusion? In responding, never insist that they're wrong, and do not debate the delusion. Delusions are fixed, false beliefs, and they feel very real to the people that are experiencing them. Try not to take any false accusations personally, and no matter what your beliefs are, always show respect for their perspective and gently offer your own view. We encourage you to respond to the feelings caused by these delusions, not the facts. Delusions can be very frightening and distressing to those who are experiencing them, and these feelings are definitely real. In general, try to establish if the delusions may be related to stress or anxiety. Are there triggers you can identify? Do any interactions or events seem to increase delusions or anxiety? For example, certain visitors or family members, violent or emotional TV shows, times of day, or other stressful events. In your guide, pages 23 and 24 have charts showing suggested language for working with residents with paranoia and delusions. Again, remember to try to establish a relationship of empathy and trust with the older adults you're assisting, and promote coping strategies for stress or anxiety that may be the triggers for their paranoia or delusions. Encourage compliance with medications, and for them to avoid alcohol. Promote social and physical involvement and engagement in community activities. Validate any part of a resident's delusion that could possibly be real. Maybe there were unknown workmen in the building, or perhaps the heating system was making noises that sounded like someone was banging on the door. And then develop a strategy for managing the symptoms with the resident. Would an extra lock on their door or a daily check-in help to make them feel safer? We understand that this is not easy and it takes a lot of time and effort. Working with someone who's experiencing delusions can be difficult, so always be aware of how you feel and get support from other staff when you need it. In response to the unsubstantiated odors and leaks that Margie complained about, you might try saying to her, "It must be scary to think there is gas coming in through the vents. Perhaps what you smelled was related to the work we were doing on the roof. I think they use an adhesive that has a strong odor. We've tested the air coming through the vents to be sure that nothing is coming in, but I'll make a plan with maintenance for ongoing routine air quality checks just to be sure and to set your mind at ease."
Unfortunately, there are barriers to helping older adults like Margie in accessing mental health in the United States. It's important to be aware of these barriers and begin to think about ways in which we as a society can break down some of these barriers. Only 25% of seniors needing mental health services access those services. Why is that? Stigma. Stigma is huge for many cultures, and many elders view mental illness as a tragic character flaw or a sign of weakness, as not a treatable disorder. Many also worry about taking psych meds. I won't be myself. They may view their depression as weakness, or they may feel this is just how old age is. Remember, depression is not a normal part of aging. This is where education and conversation can help people understand that they're not alone and help is available. And treatment works. 65 to 70% of older adults that are treated for depression do get better. Cost, transportation, and availability of mental health professionals are additional barriers to obtaining treatment. These were barriers that Margie perceived in getting services and visiting a doctor. These issues would need to be worked out with her in order for her to access services and receive proper health care. In the U.S., there is only one geriatric psychiatrist for every 1,000 older adults, and by 2030, there will be only one for every 6,000 older adults. Because of this, often older adults go to their primary care physician to discuss mental health concerns, and the primary care physician often just takes care of it and writes a prescription. It's important to understand that primary care physicians are not experts in psychiatry, so if possible, older adults with mental health issues should visit a geriatric psychiatrist for care. Due to inadequate reimbursement, most mental health professionals are not willing to accept Medicare or Medicaid, nor are they willing to make home visits any longer, which are much needed by older adults that are not able to easily travel to appointments. And for older adults who do not speak English, it can be extremely challenging to find mental health professionals that speak their language. It's helpful to be aware of the mental health treatment resources that you do have in your local community and get to know them so that you have somewhere to turn when an older adult you're working with needs a referral. Veteran Services may also offer resources for older adults who qualify. Most importantly, again, think about collaboration.
Now, let us introduce you to Florence Jones.
I don't know what's happening around this hellhole. Everything's gone to pot. Nobody takes care of this place except me. And these low-life tenants are running amok. Most of them, they don't even speak English. So who knows what nonsense they're up to. Someone, and I think I know who it is, bangs on my door every night, and I haven't had a good night's sleep in weeks. His son is out to get me too. I know that he was the one that banged up my car in the parking lot. I have proof. But management is filled with useless bureaucrats that sit on their hands all day, and they won't do anything about it. They're always sticking up for the minorities. But the tables have really turned now. It's me who's the minority here. I don't know what it's going to take to find just one person who has their wits about them to pay attention to the people around here. Until then, I'm going to take matters into my own hands.
Florence Jones is a 75-year-old woman who has lived in senior public housing for 2 years. She moved from a neighboring town because she alleged poor management practices in the housing there. She's divorced 3 times and has several children and stepchildren with whom she has complicated and volatile relationships. Florence, or Flo as she likes to be called, was very engaging when she first moved in and immediately volunteered to help set up activities and work as a volunteer at the front reception desk. She initially stated how wonderful the building was maintained and expressed her gratitude to management. But after about 6 months, Flo started complaining about everything from landscaping to the business office staff and was stirring up other residents at the resident council meetings. She reported that people were repeatedly banging on her door in the middle of the night. And recently, Flo had a loud argument with another resident at the front desk. And this included her use of a racial slur, which frightened a visitor's grandchild. Security was called, and both residents were warned that their behavior constituted a lease violation. Flo was removed from her volunteer position at the reception desk. She was really angry about that and then accused the resident's son of being out to get her, made accusations that the son purposely scraped and dented her car that was parked in the parking lot, and Flo called the police to report this incident, which she described as bullying and harassment. Please note that the car was very old and had multiple previous damages, making it hard to determine if any of the damages were new. Flo has been lobbying other residents to side with her against the other resident and management. She has made calls to the Housing Authority and the Board of Selectmen stating that building management is discriminating against her as one of the minority white residents in the building. She's also filed a complaint with the Town Board of Health claiming improper food handling at a special luncheon and told other residents that they were exposed to diseases because of this. The following are some concerning behaviors and changes you may have noted about Flo. Note her history of multiple divorces and estrangement from family, especially from her children and stepchildren. Does she have difficulty maintaining healthy relationships? Remember, she had a previous move due to dissatisfaction with management. Are any of these things red flags? What are her concerning behaviors? Flo often did what we call splitting, which is a common defense mechanism used by many people in which the individual tends to think in extremes. For example, an individual's actions and motivations are either all good or all bad, with no middle ground. Note that her positive attitude about housing shifted quickly, and Flo now was reporting multiple complaints and expressions of dissatisfaction about the building and staff members, and she was pitting staff members against each other. Flo's speech and affect had become angry and hostile, and there were increasing inappropriate uses of racial slurs by Flo. She seemed to be lacking the ability to filter her comments. Physically, she often appeared anxious and agitated. Her mood was irritable and hostile. Her cognition had changed. She was showing possible signs of paranoia, the belief that the resident had intentionally damaged her car, delusions and hallucinations. Remember the banging on the door in the middle of the night? Some other concerning behaviors included increasing hostility towards residents and staff. So what is going on with Flo? Differential diagnostic possibilities may include a personality disorder with possible depression or anxiety or bipolar disorder. And again, it would be important that she have a medical exam to rule out a urinary tract infection or any physical problems, and a mental status exam to rule out dementia. Let's talk about some of the dilemmas staff may face in working with Flo. Flo doesn't have any family in the picture. Remember, she was divorced and not in contact with either of her 3 ex-husbands, and she's seemingly estranged from her children and stepchildren. To our knowledge, Flo has no known social support. And how is her behavior impacting the community? She's been disturbing the peaceful environment by frightening residents and their visitors, and stirring up other residents with her complaints, especially about the health concerns. Remember that because Flo was initially cordial, there were people in the building who liked her and believed some of her complaints and believed that her accusations were valid. She poses a possible threat of violence. Her hostility towards staff and other residents and use of racial slurs is unacceptable and very concerning. The community police and town officials are getting really weary and frustrated with the time spent dealing with her constant reports. To move forward in planning, we would recommend that an ACT team be put together, and this diagram highlights the key players or the village that would be instrumental in assisting Flo. Planning for Flo would likely include first scheduling a resident at risk team meeting described on page 7 of the guide. These meetings should include all staff and focus on working with any resident whose behavior has been worrisome, problematic, or who may have a lease violation. Each staff member brings their own area of expertise to the table, making for a balanced approach in problem solving. Together, a plan is created in how to work with the resident based on a unified approach involving the key players. the team would brainstorm on how to best set boundaries for flow, and this could be accomplished by encouraging the use of close communication with staff to minimize the effects of splitting and by setting limits on how much time staff spend with flow. The staff may want to consider assigning a rotating staff member to become her go-to person for complaints in an effort to reduce the total time spent by the entire staff. At future meetings, progress reports would be made in an effort to follow up. In Flo's case, the resident at-risk meeting should be followed by an ACT meeting, including the key players from the community that we mentioned in the previous slide. The goal of these meetings would be to provide some clarity on Flo's accusations and allow for recommendations and suggestions for follow-up, such as beginning with a thorough physical evaluation, then moving to a neuropsych evaluation to rule out cognitive impairment or mental illness, making a referral for mental health treatment, knowing that it's likely that Flo may resist engaging in treatment. It is likely that Flo may view mental illness as a stigma, which would be a huge barrier to overcome. The RSC should also make efforts to engage Flo in some type of community activity that might be more positive and productive, possibly working on the community garden or involving her in the exercise group as a way to redirect her energy and re-engage her in the community. And often, the use of a lease violation and threat of eviction can be used with someone like Flo as a tool to strongly encourage the resident to seek or accept intervention in order to effect an improvement in behavior. This is outlined in more detail on page 27 of the guide. And if Flo continues to use racial slurs and be aggressive and hostile, it will be important to know how to de-escalate her behavior. Some of these techniques are discussed on page 6. Remember, when trying to de-escalate someone who's angry or aggressive, please keep safe and don't meet with an angry resident in a closed, small space. Sit closest to the door and always with access to a phone. And if you believe you're in any danger of physical harm, never hesitate to call 911. In terms of verbal communication, use a respectful tone and call the person by their name and use their title. Something like, "Mrs. Jones, I hear that you're very upset and I want to help. Can we talk?" And if Flo is verbally abusive, tell her you'll be able to help her. You won't be able to help her until she's calmer. Without saying, "Just relax," as that may be perceived as condescending. Instead, say something like, "Mrs. Jones, it's hard for me to listen when I hear screaming and swearing, and I really do want to hear your concerns." Set limits and do not tolerate abusive language or actions. Say something like, "If you continue to swear at me, I will need to end this meeting." The chart on page 7 gives more examples of suggested language for someone who's angry or upset, and the chart on page 17 refers specifically to use of language with someone who has a personality disorder. As we noted earlier, pages 23 and 24 also offer suggested language for use with people who suffer from paranoia and who are having delusions. In the case of Flo, it's unclear if she's suffering from these issues or simply making false accusations. That determination should be left to a mental health clinician. But when she's reporting the banging on her door or reporting her car being purposely damaged by other residents, a helpful response may be, "I understand that you're upset about the banging on your door. Is it possible the noise might be coming from the radiators kicking on in the middle of the night? And it must feel very frightening to think that there's a conspiracy against you." In conclusion, remember to seek support before you need it. Don't try to go it alone. Your work can be difficult and stressful, but remember the power of collaboration. It takes a village. We can't always solve everything, but we can mitigate risks, and knowing and understanding the component parts of approaching each situation will provide you with a framework so that you're not reacting by taking these difficult situations personally, but by reacting in an informed, thoughtful way using all of the resources available to you in your community.
Please feel free to download these helpful guides and to share them with your colleagues. We hope that today's webinar has brought to life our tips and techniques guide for supporting residents with mental illness, and that it will be a helpful tool that can be easily referenced when you need it. This link will also lead you to our guide to suicide prevention in senior housing, which is a practical guide that should be read by all staff or people in the community. It may help save a life. Thank you so much. We're happy to be of support in your efforts to improve the lives of the older adults in our communities. Please feel free to reach out and contact us if we can be helpful in the future. We appreciate your spending the time with us today to enrich the important work that you're doing every day. Thank you.